thinking about immune checkpoint therapy, we have this historical artifact of the, ipilimumab being introduced first, PD-1 antibodies being evaluated in ipilimumab refractory patients, and associated with, response, percentages, some of which are in FDA labels. Then more recently, you get PD-1 inhibitor monotherapy data, which of course, I think is what we think about when we're talking to patients, about predicted outcome. So, Jason, you got a patient in front of you. I mean, make it easy and say they're BRAF wild type. And you're preparing to have the discussion with the patient about PD-1 monotherapy versus PD-1 CTLA-4. But hold off for a moment on that combo part. Just, how do you describe the upsides and downsides of PD-1 antibody monotherapy?
Well, the way I usually describe it to patients is sort of take them through the historical progression. I usually actually start from IL-2 and then go to IPI and then go to talk about the progression that we've been making with serially increased response rates and durable benefit over time. And when you get then to PD-1, you then sort of identify that now you have a 40% response rate relative to prior 10, and it looks like there's a durable, at least like maybe in the 30% range, number of patients are out a long time, and you actually decrease the side effect profile relative to prior immunotherapy approaches. And that, it's a pretty convincing argument that this is the right thing to do. But I think there's really no debate in the field now that in the immunotherapy space, PD-1 antibodies are now like the core of immunotherapy. In melanoma, probably more cancers actually. So I think that part's very easy. The question then is going on to the combos, and right. So,
but I think a setup for that. So a nice summary on the efficacy side. But when you're talking about toxicity, the problem with the discussion, if you just go based on lifting data out of a New England Journal publication, is you get the kind of noise of some symptomatic toxicity, some laboratory abnormalities. So for PD-1 monotherapy, how do you quote to patients, problematic toxicity, and then maybe you could kind of frame that also as may require steroids. I mean, like, what's that percentage? Because I think that becomes then the kernel of the safety side of efficacy safety with PD-1 monotherapy that then helps set up the discussion for combo.
Well, I usually quote to patients the incidence of clinically meaningful problematic side effects is going to be in the range of 10 to 15%. That's usually what I quote to patients. And I put that in the context of ipilimumab, where I usually tell them somewhere under 30%. So that's a clear improvement. And I really spend a fair amount of time emphasizing mechanism of action of these drugs to explain to them why it's different. This isn't like a pill that you took that if you just let it wash out, it goes away. But in fact, this is your own body manifesting an unusual response against itself. So I think I describe that, then to go through them serially, to really just force the idea that if something's unusual, you should let us know. Yeah. Because sometimes these aren't as obvious as, especially in the monotherapy PD-1, you don't see much grade 3, 4 colitis, but things can happen. And I tell patients the most common are some fatigue. That seems to be very consistent. We see a fair amount of arthralgias in the Midwest, at least, and I think that is an area that needs to be explored that we don't understand mechanistically well, but it's quite common. And then cutaneous things sometimes, some rashes, and so on and so forth. And then anything beyond that, it's call us, because it could be, and we need to sort of sort it out further. Yeah.
So, I mean, Jeff, you've had a lot of experience with these drugs for a long time. So what's the kernel of autoimmune toxicity with PD-1 antibody therapy that really worries you? I mean, right, so patients can have grade 3 rash, and that's great, that's going to be a problematic rash in terms of patient being uncomfortable and so on. But leave aside, the vast majority of skin toxicities. What are the ones that really kind of, again, make you kind of nervous, make you jump into steroids, and then, what's that percentage look like in the population you treat?
Well, let's back up 1 second. Jason said, talked about the clinically meaningful toxicities. Usually when we look at a toxicity table in a publication or on the package insert of a drug, it just gives you a list of how many grade 1, 2, how many grade 3, 4 toxicities are there. But I think with these drugs, you have to go beyond just the listing or enumeration of the toxicities and ask 2 questions. How often do you have to stop the drug, and how often do you have to intervene with steroids or other drugs? And actually for Pembro and Nivo, and probably the PD-L1 antibodies also, it's only about 4 or 5%. I mean, that's the stuff that I think patients really care about. I mean, you can certainly have morbidity from severe rashes, but usually if it's something you don't have to intervene in, it's not more than an annoyance. It's the colitis where you have to intervene, the neuropathies, the nephritis, the hepatitis, and that's pretty low. 4 to 5% is a very well tolerated.
I guess the other one thing I want to throw in when thinking of this number, I guess we're kind of parsing if it's 5 versus 10, but
Yeah.
considering how low that is, I mean, I tell people PD-1 antibodies is like safest drug we have in all of cancer, really.
Yeah,
But
right. So-
the other big one I didn't mention is thyroiditis.
Yep.
It's very, very common that patients will get, and sometimes asymptomatic, but abnormalities in the thyroid. And just because a patient learning they have now a thyroid problem, that can be oh wait, why do I have this? But it's really not a big issue, but that's why I raised it.
No, I
clinically
would
meaningful,
agree.
'cause I think patients feel that it's meaningful, they have to start taking levothyroxine or something like that. But in reality,
Yeah.
it's not dangerous.
No, I agree. I mean, just to second Jeff's point, I boil it down the same way and end up with I present to patients kind of a 5% number of, this is the real kernel of toxicity that, is truly problematic. But then obviously the transition point here is to PD-1 CTLA-4 combination therapy. So numerically in trials, reported grade 3-4 rates of 50 to even 60%, depending on the cohort. But let's do that again for what's the kernel of concerning toxicity within the combo PD-1 CTLA-4.
So I have very similar conversations about single agent PD-1, and when it comes to the combination, I take it up a notch. In fact, you can almost guarantee they will develop some sort of toxicity of some kind when you're combining CTLA-4 and anti-PD-1. Colitis is an issue for me, not for me, for the patient. It's the most worrying concern because I actually get concerned about them sitting on side effects and not reporting it. I would rather, and this is what I think is really important, I would rather a false alarm than no alarm. So I tell them, the big 5, same conversation that Jason has. We're stimulating your immune system. It's something that we need to stop with heavy-duty drugs if it starts affecting your normal tissue. And the big 5 are your gut with diarrhea, your liver with hepatitis, endocrinopathies, so your pituitary, and that can be dangerous, thyroid, skin, and then it can affect almost any other organ, but in much lower percentage. But if you're concerned or worried, you must contact and let us know of any little symptom. Let us interpret whether we think it needs more follow-up or more intervention. But early intervention is what's required. I have to say, I warn them that they will get some sort of side effect. I prime them for that. Now, if they're one of the lucky few that get through without any side effect, good luck to them. But the most important thing is managing these toxicities early and quickly, and then it is manageable.